morning, good evening, good afternoon, good night, friends and colleagues from all over the world. My name is Dr. Kian Rashab. Welcome to today's program. We have two special guests today. Our host, Dr. Kevan Javid, which you guys are very familiar with, and also a regent of the Global Summits Institute, and Dr. Kenneth Lee from Australia. Thank you for joining us.
Hi, thank you.
A pleasure.
So, gentlemen, in terms of this morning, we had our wonderful friends from Canada. Now we're going to Australia, and some good surprises tomorrow morning. But I kind of wanted to give you guys an update on how this project has formed and shaped thus far. We crossed the 500,000 mark of our peers on Mother's Day, and as of today, we're a little bit over 530,000. And from the analytics we have pulled up, we are touching and reaching our colleagues in the most distant places, as you see on the lower right. It's an honor to be part of this project, and we would like to thank you on behalf of our board and all of the 150 plus dentists that are currently working on this project, many around the clock, to thank them for their contribution to this peer-to-peer project. With that said, please, I'd like for Dr. Javid to take over the discussion here and introduce our speaker of the day. Dr. Javid, you have the floor.
Thank you. Welcome to the Global Interdisciplinary Summit, where 100 top doctors from all around the world come together and share their knowledge with their colleagues. Today, our super special guest is Dr. Kenneth Lee. Welcome, Dr. Lee. It's an honor to have you with us.
It's a pleasure to be here. In Australia, when we greet someone, we usually say, good day. So good day to you.
Thank you. Dr. Kenneth Lee is committed to creating super dentists. He's currently a practicing dentist in Sydney, Australia. The principal of Today's Dental, which is a multi-location group practice running for over 30 years, is the same location, same practice. His personal practice is primarily limited to orthodontics, TMD, sleep medicine, and implant dentistry. Over the years, he has never stopped furthering himself in these key areas and receiving many accolades to evidence his mastery and experience. These include by examination, fellowship in International Association for Orthodontics, International Congress of Oral Implantology, American Association for Functional Orthodontics, American Academy of Craniofacial Pain, World Academy of Ultrasonic Piezo Surgery, and International Dental Implant Association. Diplomat by examination for International Congress of Implantology, International Association for Orthodontics, and World Academy of Ultrasonic Piezo Surgery. He continues to be an active and driven member in numerous international dental bodies, including being a past president and currently the chair of education for the International Association for Orthodontics, International Congress of Oral Implantology, the International Dental Implant Association, and the World Academy of Ultrasonic Piezo Surgery, of which he's a diplomat and international board member. He also sits on the esteemed Global Scientific Dental Council for AEEDC, Dubai. He is a professor of postgraduate studies at University of Jamaica, where he is currently teaching and supervising postgraduate dental students in the field of oral implantology and orthodontics. He is a frequent and renowned teacher, both nationally in Australia and internationally, whose catchphrase whilst teaching and treating is, above all, do no harm. He is a founding faculty member of the International Academy of Advanced Dentistry in Sydney, Australia. IAA Dent holds courses approximately 30 weekends per year all around Australia, teaching graduate dentists all aspects of orthodontics, TMD, and implant dentistry. As IAA Dent's principal teacher, he passionately strives to bring fellow dentists to the forefront of dentistry, creating super dentists who are enabled to create healthier people with beautiful smiles. His ultimate aim is for the doctors to provide exceptional care for all our patients and our community. Dr. Lee?
That's very, very kind introduction. And thank you very much, everyone, for hosting this and coming in to listen to us. Are there any housekeeping we need to get done first before I proceed?
I think we're ready.
We're ready?
Yeah.
Okay. So greetings from Sydney, Australia. As you know, besides the introduction, the wonderful introduction which I got, I'm a practicing dentist from Sydney. I have 3 clinics in Sydney, and the primary thrust of my practice is, as you know, orthodontics, TMD, sleep, and implant dentistry. If you've never been to Sydney before, please come and visit. It's one of the prettiest and most beautiful cities in the world, somewhere where I'm very proud to call home.
Hey, Doc, sorry to interrupt. Could you kindly put your presentation back into the stream so I can pull it up?
Okay.
Let me see. There we go.
Are we up and running?
Up and running. There you go, doctor.
All right, up and running. We're back. We're back. All right. So come to Sydney. The take-home message is: come to Sydney. Come visit. It's a beautiful city. I'm one of the foundation faculty for IAA Dent, International Academy of Advanced Dentistry, where we try to up the bar for general dentists, show them aspects of orthodontics, TMD, and airway dentistry, sleep dentistry, which they may not know work quite so well after university. Same with implantology. I've already been introduced, so I won't say much more about that, except for the fact that when it comes to the International Association for Orthodontics, I'm only the 2nd non-American to become president of the largest orthodontic organization in the world, non-specialty organization. So it accepts members from all aspects of dentistry: general dentists, pediatric dentists, orthodontists. So any dentist can be a member of the IAO, which I strongly recommend if you're interested in orthodontics. As a disclosure, I am on faculty for IAA Dent. I am in private practice in Sydney, Australia. I don't receive any income from other commercial organizations, and nor is there a conflict of interest with any products or endorsements which I may talk about, and I'm not given any benefit from talking about anything favorably. I'm also a faculty member of UG University. Okay. So over the last 30 years, I've noticed that there's been a big intersection going on between airway, sleep, and orthodontics, and TMD. And that's something which in the old days, we would never have considered, that, airway and sleep disturbed breathing, TMD, and orthodontics was actually related. In fact, when I went through university, we were told that there was actually no relationship between airway, sleep disturbed breathing, TMD, and orthodontics, and they were all separate disciplines. But over the years, there's been an increasing body of evidence coming out within and outside the dental profession that would indicate that there is. And so I think that one of the main purposes of this talk is to bring to the attention of the greater dental community the importance of understanding your patients, your growing patients and your adult patients. If they do have a breathing disorder or they do have a limitation on breathing, that may contribute to the whole quality of their life. It may contribute to some kind of TMD problem, like a parafunctional problem. And for a growing patient, it could be a contributing factor to their orthodontic issues. So I think these 3 things, we call it the grand central interchange. There's a crossroads where all these disciplines actually meet and follow a parallel path. And so we need to look at, when we look at an ortho patient, we also check for TMD. We also check for airway. When we look at an airway or a sleep disturbed patient, we also look at check out their TMJs, check out any issues concerning TMD. We also check if we see there's any orthodontic issues, and vice versa. And the last thing is, if we have a TMD patient, we check their airways and see what their airways are like and how their teeth occlude orthodontically and what their skeletal pattern are like. And there's a lot of interchange going on between these three topics. And for those who treat it, you know exactly what I'm talking about. And for those who don't treat it, start looking. Start looking, because you will change lives. So when thanks to I like to thank the IAA team. I have a great faculty that help propagate this way of thinking, and I like to thank them for helping put together all our presentations, and from Today's Dental as well as from IAA Dent. And I really appreciate all the efforts which our team has gone to. And what you see in front of you is not purely my effort. It's the effort of the whole team. And for that, I'm truly appreciative. So you walk into your practice and you see someone like that, okay? Some of you would say, oh, what a pretty gal. What a cute, she's as cute as a button. But if you were to look more objectively, and if you were to look more with clinical eyes, you would see there's some issues going on. And I'll just point out a few issues here. If you see from a patient with, for example, with the whites showing underneath the eyes on a regular basis, that may be an indication that it warrants further investigation. If you see venous pooling beneath the eyes, right, that would warrant further investigations. You'd be asking yourself, what causes venous pooling to occur? So, is it allergies? ENT people call it allergic shyness. Is it an underdeveloped maxilla? Okay, because underdeveloped maxilla would manifest itself as showing venous pooling. Could it be deoxygenation? Is the patient not getting an adequate night's sleep? Are they not sufficiently oxygenated? You'd ask these questions. You'd have a look at their nostrils, and if they've got really small nostrils, you need to ask why, because we should all be breathing through our nose. Have a look at the ears. Do the ears look the same? You'll see one ear looks a little bit more protrusive than another. So if you look at it from a craniofacial point of view, you would diagnose that as an external rotation of the temporal bone. Okay, so the external rotation of the temporal bone has the effect of bringing an ear out. So you can start seeing here now that this particular child has some cranial distortions going on. Now let's have a look at the cheeks. The cheeks look a little bit flat and underdeveloped. So flat and underdeveloped cheeks also could indicate an underdeveloped maxilla. Have a look at the lips, thin lips, okay? An open mouth posture, okay? So what does flaccid lips or an open mouth posture indicate? A possible mouth breathing habit. And if you ask the patient to put their lips together, if you see a golf ball stippling on their mentalis muscle, that means they're incorporating accessory muscles to close their mouth. So everyone should be able to, if you're a nasal breather, everyone should be able to breathe through their nose, have their lips together touching lightly with no excessive muscle hyperactivity going on. There should be no excessive mentalis activity going on. That's incorporating the wrong sets of muscles, accessory muscles. Have a look at the head tilt, okay? Have a look at the shoulder roll. So posture plays an important role. A lot of times, if you look at a child with poor posture, it may be to compensate for a breathing problem, a breathing issue, okay? So there's all these different things you look at. Do they have a forward head posture? Do they have a sloping forehead? where does their mandible look in relationship to the upper 2/3 of the skull? If they have a retrusive mandible, they may have some kind of airway issue in the oropharyngeal area. So these are some issues which we look at. When they smile, now, this is a very young patient, but already they're developing a gummy smile. So the things you'd be looking at for a gummy smile is, do they have a canted down premaxilla? Do they have vertical maxillary excess? Do they have a short upper lip? So these are the things you need to investigate further. And you need to find out the reason why they have a gummy smile. Okay? And it could be from poor oral posture. Have a look at the arches. Are the arches well shaped and parabolic and horseshoe? As you can see, this is all deciduous dentition, yet the teeth are very, very close together. Ideally, for a deciduous dentition, you want to see nice spacing between the teeth, because the nice spacing indicates that there's sufficient space for the adult teeth to come through. So when you see a situation where you've got a lingualized dentition, teeth are close together, then that would be maxillary constriction. So something's happening to the size and shape of that upper jaw. And because the lower jaw is trapped underneath, we have what's known as victimization. And have a look at these lower teeth, the lower incisors. Even at this early stage of her development, there's quite a bit of crowding going on. Okay? Even at this early stage of development, there's quite a bit of crowding going on. And in our terms, we call that victimization. And that's a victimization because of maxillary insufficiency. In other words, the top jaw is the wrong size and the wrong shape. It's trapping the lower jaw, not letting the lower jaw develop to its full genetic potential, and buckling the lower jaw. That's called victimization. And as I was alluding to earlier, you can see a compensatory postural change in your patients, and a lot of it comes from airway. So if you have a constricted airway, if you have a very constricted, say, for example, oropharyngeal area, it's very difficult for the patient or for the kid to sit upright. And you've got mum and dad saying, sit up straight, sit up straight, sit up straight. But they can't do that. They can't do that, because if they were to sit up straight, like soldier straight, shoulders back, chest out, chin in, they would basically self-suffocate. So they would do a postural compensation, which would mimic something like, I'll show you, like this. They would have a forward head posture. They would have a forward head posture. They would have rounded shoulders, maybe a hollowed chest, to facilitate easier breathing. So have a look at the patient's posture, because the posture, their head and neck posture, as well as their shoulder and body posture, also gives you an indication as to how the patient is tracking and how healthy they could be. Okay, so if you have rounded shoulders, forward head posture, sunken chest, how healthy can the patient be? That's the question you, the doctor, has to ask. How healthy can the patient be? So it's all about correct function. Okay, getting everything to function, especially for us dentists, it's the oral function correct. Are they functioning correctly? Now, what we need to have is nasal respiration, lips slightly touching, tongue in the right position. So if you were all to do this exercise, if all of you were to take 3 breaths, have your lips slightly apart, just very, very slightly apart, and breathe through your mouth, take 3 breaths. Note your tongue posture. Then put your lips together and take 3 breaths through your nose. Note your tongue posture. So when your lips are together and you're breathing through your nose, the tongue tends to automatically sit behind the upper front teeth, thereby helping shape the palate. If you're breathing through your mouth, the tongue sits low and doesn't have an effect on maxillary development, that horizontal aspect of maxillary development. So the only muscles that are working are some aspects of the orbicularis muscles and the buccinator, and the arches become constricted. Then you get that V-shaped arch. Then you get the lingualized occlusion, and that's what we see. So it's all about getting correct function, but correct function starts with correct breathing. Okay, so as you can see, when you're babies, if you look at babies they sleep with their lips together and they breathe through their nose. Okay, that's how we were intended to sleep. That's how we are intended to breathe. We should be breathing through our noses. And some things are actually counterintuitive or counteracting that. For example, bottle feeding as a generalization may not be such a good idea, because bottle feeding interferes with the correct swallow pattern. And we can talk more about that in the future. As does feeding mush. And mush is soft, gooey food. And I see that in everywhere in Australia, in the food centers. Parents are feeding their baby mush, and then the mush gets everywhere, and then they use a spoon and they scrape up the mush from the sides of the mouth. That's known as perioral stimulation. And as a baby transitions from what we call an infantile swallow to an adult swallow, your chewing and swallowing pattern changes. Now, when a mother brings a baby to breast to get them to feed, they do this. That's called perioral stimulation. And that's the indication, that's the trigger for the baby to start basically suckling. So and the suckling is it incorporates the infantile swallow pattern, where they can breathe and swallow at the same time. Okay? But an adult swallow pattern is very, very different. It's when you have to chew, epiglossal close over, and then you swallow. So if you give a patient the wrong signals, so if you give the baby the wrong signals by doing perioral stimulation, when you're trying to transition them into an adult swallow pattern, then you may be confusing their brain, and then they may develop an aberrant swallow pattern. So you got to look at things like that. So maybe bottle feeding is not such a good idea. Maybe feeding them mush and doing perioral stimulation by cleaning up the mush from their face as you're feeding them may not be such a good idea. Okay? And that will lead to an aberrant swallow pattern. That will lead to maybe an aberrant breathing pattern, and that may lead to cranial distortions. And these cranial distortions will lead to craniofacial dysmorphosis. In other words, the face and the face doesn't develop to its full genetic potential. That the face doesn't develop as well as it should. Okay? When babies are asleep, they should have their lips lightly touching, and they should be breathing through the nose. If you see a picture like that where the baby is actually on their tummy, bum up, head to one side, mouth open, this is actually an alarming picture for me. It's an alarming picture because the baby, is trying to get air. This is actually their posture which the baby has to take to actually breathe well. Okay? So to breathe properly. So some people can say, look, we'll look at this picture and say, oh, baby's so cute. Actually, it's not so cute. Actually, it's an indication that the baby has some kind of sleep disordered breathing. That something is going on that's affecting their sleep and quality of sleep. So they have to change to this posture just to be able to breathe when they're asleep. The ramifications are profound in growing patients and babies. It affects brain function, it affects body function, and it affects basically every aspect of growth and development. Okay, I can't stress the importance of correct breathing on babies and growing patients. So if that's not looked into, then the patient will not develop to their full genetic potential. And that's what all parents want for their kids. Parents want their kids to be apt to be the best they can be. And if we allow this to happen and not say anything about it, then we're not allowing the kids to grow to their full genetic potential. So what are some symptoms of airway problems? The most classic is mouth breathing, okay? So if the patient is a chronic mouth breather, then you know that they have airway problems, okay? Cracked lips or soft tissue gingivitis, something we see every day. Venous pooling beneath the eyes, okay? A change in head posture. Remember I said, so you can either have a sloping head, so you have a choice. Either they bring their head forwards and crank their neck forward to breathe better and round their shoulders, or they may put their heads back and have the sloping forehead to breathe better. So you have a look at their head posture, and that would indicate also that they're trying to get more air. Subconsciously, people don't realize they're doing this, but the survival mechanism overcomes everything. So in order to survive and do well, they will change their head posture, okay? If you see that they have adenoidal and tonsil problems, that's an indication of airway issues. Reflux in the station tubes. In Australia, we call them grommets. And what happens is, it's the middle ear. It's supposed to have a slight gradient to drain. And if you have an underdeveloped maxilla, that middle ear is horizontal. And because it's horizontal, it doesn't drain properly. So if you were to develop the maxilla to its correct genetic potential, then the chances of having eustachian tube reflux will be much, much lower. That in turn is associated with conductive hearing loss. And because there's a change in the head and neck posture, you could get associated head and neck pain. We see that a lot with our TMD patients. Not only do they have sore joints or sore TMJs, but they also have associated side and posterior neck muscle tension and pain. Try and imagine, the head's about as heavy as a bowling ball. And if you have a change in head posture, you put a lot of stress on the cervical neck muscles. And that in turn has to have a compensatory behavior down the rest of the body. So what happens up here affects basically the whole body. The whole skeletal muscular system has to compensate. And that's why it's so important for us, the dentist, to be able to recognize and see what the problem is and help the patient seek help from other health practitioners as well. So nasal breathing. So one of the basic fundamentals to good health is to be able to breathe well, okay? And to breathe well, you need to breathe through your nose. The functions of breathing through your nose is it warms and humidifies the air. So it warms and moistens the air. It acts as a filter because there's a lot of particles and a lot of, basically in Australia, in our slang, we call it crud. There's a lot of crud in the air. And Sydney is the allergy capital of one of the allergy capitals of the world. And so we have a lot of allergies in Sydney. And so we have to be careful about that. So there's a lot of crud in the air, and we don't want it to go straight down to our lungs. Okay? So nasal breathing has a role in olfaction, in phonation, and also very, very importantly, what people don't realize is that breathing through the nose and the interaction of the filtered, warmed, moist air through the nose, going through the nasal passages, mixing with the sinuses, gets that oxygen, nitrogen, carbon dioxide ratio correct for maximum genetic output. Okay, so it's for maximum cellular output, for maximum health. You will survive by mouth breathing ambient air, but you won't thrive. If you breathe through your nose, you will be at your maximum genetic potential. And that's why it's so important to nasal breathe. So if you look at a face, and ear, nose, and throat specialists have long known about this. They term this as the adenoidal face. Okay? And that's when a patient has breathing issues and breathes through their mouth habitually, and they develop a long face. So as you can see, this patient here has a problem, has a long face, but has other problems. If you look at the face, if they bring their lips together, there's a lot of tension in the mentalis muscle. It's an effort to bring the lips together. Okay? As a result, you've got quite a lot of mandibular retrognathia. In other words, the mandible is set back in relationship to the rest of this face. Okay? Not only that, the maxilla is actually a bit too far back as well. If you look at the shadow, you can see the shadow of the patient, and it gives you an idea. We have venous pooling, we have flat cheekbones, we've got the whites showing underneath the eyes, we've got quite a bit of facial asymmetry going on, and so this is what is coined the adenoidal face. Okay, this is coined the adenoidal face, and this is something which we commonly see, and it's all about correct development. The way our head develops is our face develops is that we go forwards and downwards, forwards and downwards, forwards and downwards. If your lips are not together lightly, your tongue's not in the right position, if you're not nasal breathing, if you're not breathing through your nose, if you're keeping your mouth open, then you have a greater vertical component of growth and less of a horizontal component of growth. And that's how you get the long face syndrome. So so as a result, this particular patient has most probably not reached their full genetic potential. Okay? So the adenoidal face is characterized by a long lower face, an open bite, possible cross bite, retrognathia, vertical and posterior rotation of the mandible, sometimes a gummy smile, a high arched palate, and marginal gingivitis of the upper incisors, and a class 2 or a class 3 occlusion. And that's something we see very, very commonly. Okay? So mouth breathing causes numerous problems. Dysfunctional breathing being the most common. Okay? Upper respiratory tract infections. If you're breathing through your mouth, it hits all the lymphoidal tissue like your tonsils straight down and shocks the lungs with cold, dry air. Okay? And the muscles and the lungs go into spasm. Some people call that spasm an asthma attack, maybe. Okay? Ear infections, okay, from an underdeveloped maxilla. Dental erosion, bad breath, malformation and malocclusion of the upper arch leading to crowding, raised vault, long narrow face, narrow maxilla, and retruded mandible, and many, many more problems. So a lot of these problems can be avoided if we get the breathing correct and the oral musculature correct. Okay? Oral myologists play a very important role in this too. If you just look at a face like this, and I can't find my arrow. If you look at a face like this and you see crowding going on, that's not a good thing. That means that the lower jaws haven't developed to their full genetic potential. Okay? Again, you see the venous pooling under the eyes, the poor oral musculature. Okay? And you know something's going on. And we can intervene and we can recognize these problems from a very, very early age on our patients. And that's what we should be doing. We shouldn't be waiting until the patient is 12 or 13 years old and say, oh, we're going to do orthodontics. That time has passed. We should be identifying developmental issues and correcting them early on. And you can correct them by getting the patient to breathe correctly, get the oral musculature correct, okay? And go and see a body mechanic, okay, to work on their bodies. That's also very, very important. So if the top jaw is too narrow, what happens to the lower jaw? Okay? The lower jaw gets what's known as victimized. So the lower jaw can buckle to the wrong size and wrong shape, or it can push back, or it can escape the bite. So you got a few scenarios that could possibly happen. but the lower jaw reacts to what's happening to the top jaw, okay? Or you may have a crossbite, unilateral, bilateral, or anterior crossbite, okay? What we want to have is a well-shaped parabolic arch, okay? A well-shaped upper arch, rounded, horseshoe-shaped, not V-shaped, not narrow, nothing like that, okay? And what we want is the maxillary and mandibular bone, the maxilla and mandible, to be in the right relationship. If you have a retrognathic mandible, then you tend to have, if the lower jaw is pushed too far back, then that will also further impinge on the oropharyngeal airway, and you have a smaller airway because the tongue will push back in that area, and that airway becomes smaller. Conversely, if you are able to move that lower jaw forward and put the lower jaw in a more forward position, the oropharyngeal region tends to be larger, and therefore the patient can breathe better. So we've got the different class types, class 1, class 2, class 3, and you need to look at the airway from the moment it enters the nostrils through the terminates to the nasopharyngeal region, right? This is the nasopharyngeal region, onto the oropharyngeal region, then into the hypopharyngeal. So, and if you look here, this is something which a lot of dentists don't look at in the nasopharyngeal area, and this is the adenoidal tissue, okay? I know that when I went through university, no one showed me how to look for adenoids. And, you know, that's so important because if the adenoidal tissue is enlarged, that would impact on the patient's ability to breathe through their nose. And you need to have a look at that as well, okay? You need to take CEFs, and CEFs give you some very good indications. It tells you about the skeletal vertical, upper incisal position, upper incisal angles, lower incisal angles, and the predominant direction of growth and how we can affect it. What we do want for good breathing and fewer TMD issues is good horizontal growth balancing vertical growth. What we're seeing a lot of, unfortunately, is more vertical growth and insufficient horizontal growth, okay? And you can see the difference from a horizontal grower, how the spine looks and how the relationship of the jaws look as compared to a vertical grower, okay? So a vertical grower has a lot more issues to deal with, potential issues to deal with health-wise, airway-wise, TMD-wise, okay? And if you have a look, most people are unaware of the extent at which vertical growth can affect the dental skeleton. And if you have too much vertical growth and insufficient horizontal growth, it changes everything with the face. It changes the relationship between top and bottom jaw, and it changes the occlusion, okay? And it usually changes it detrimentally. It also changes the available airway space, okay? So a horizontal grower tends to have more oropharyngeal airway space. A vertical grower tends to have less, and this could be a possible cause for sleep-disordered breathing. The worst case scenario, one of the worst case scenarios is obstructive sleep apnea, okay? So as clinicians, we look for simple indicators to let us know whether there's any red flags to come up. And one of the things which we use very commonly is the cosmetic or indicator line. And that gives us an idea of where the maxilla is in relationship to the anterior cranial base. So it was very famous orthodontist, John Mew, expounded that. And so it's basically the distance between the most anterior portion on the tip of the nose and the upper incisal edge, central incisal edge. And there's a formula to that, and we can talk about that later on. But it gives an indication of where the maxilla should be. So do you have that horizontal component of growth or not? So if the indicator line is out, then you may not have that horizontal component of growth, okay? We take PA CEFs or frontal CEFs, and that gives us an idea as to any cranial distortions that may be going on. So if there's any gross asymmetries, that would indicate that there's some cranial distortions going on. And that would affect the patient's head and neck posture, and that may affect their breathing as well. We have a look at their joints, okay? And joints, bone responds to pressure, okay? Wolff's law, bone responds to pressure. So if you put too much pressure on the jaw joints, the bone will change size and shape. And you look for those anomalies. And there's a whole series of anomalies you can look for, but it should be a ball in a socket, and if it starts to change shape, if the condylar neck starts to bend, if the condylar head starts to flatten, if you get beaking going on, then that would indicate that something's not quite right, okay? So you would have a look at that. If the joints are pushed too far back, posterioralized into the retrodiscal tissue, that may not be a good thing either. All clinicians should be very well versed in doing an occlusal analysis and muscle palpation. You should be able to do a full ROM, take all the measurements required to give you a brushstroke idea on how the patient is functioning. You should be able to identify, have a good knowledge of functional anatomy to be able to identify all the basic structures of the head and neck, the muscles of mastication and its synergistic side and posterior neck muscles, extraorally as well as intraorally, okay? And we routinely palpate all our patients, and we routinely do an occlusal analysis on all our patients, whether they be TMD, ortho, or airway patients, because we find there's a strong interconnection between the lot. So for occlusal analysis, we look at things like joint opening. We take 2 joint openings. We get the patient to open as big as they can, pain-free. Then I get them to open up real big as they possibly can, even if they are in pain, and I take the measurements. I listen for joint noises. I check the overbite, the overjet, the Shimbashi number. You can ask me questions about that later, but that gives me a relationship between the maxilla and mandible. I look for deviations, skeletal and dental deviations. I check for protrusion, which is the lateral pterygoid muscle. I check for lateral excursion, which is the medial pterygoid muscle functions. I look at them, I check the occlusion. I look at the molar relationships, and I do the indicator line, the C line. And so this is part of my occlusal analysis. I have a look at the oropharyngeal airway. I have a look at the tonsils, okay, and I see how big the tonsils are. So they can be grade 1 tonsils, where they're just small on the side of the pharyngeal pillars, or they can be slightly bigger than grade 2, where they start to occupy more space, or they can be bigger than grade 3, where they're occupying most of the oropharyngeal space, or they can be grade 4, where they're kissing tonsils. The tonsils are actually touching one another. So the bigger the tonsils are, the more the airway, the oropharyngeal airway is constricted, the more difficult it is for the patient to breathe, the more they'll want to mouth breathe, and the more they'll want to change their head and neck posture to be able to breathe easier. And this is all done on a subconscious level. They don't make the conscious decision to do that. They need to survive. The brain knows that they need to survive, and they will change their posture and their breathing habits to survive. It's all about the survival instinct, okay? If you do a literature review, the literature shows that there's a high percentage of sleep disorder patients with TMD problems. And these patients are more prone to occlusal issues, and some of the dentists that are doing OSA treatment have a very limited background on TMD evaluation and treatment. What I'm saying is you need to have an understanding of all 3 things to be able to treat all 3 things, okay? There's a relationship between snoring, bruxism, and TMD, okay? And if they have an airway obstruction, that leads to mouth breathing, which changes the head posture, which could lead to craniofacial pain. You know, if they mouth breathe, it could lead to dental disease. If they mouth breathe, it could lead to malocclusion. If they have an airway obstruction, they have sleep arousals, and they wake up during the sleep, and these sleep arousals can be seen by either bruxing or by having poor sleep quality. Okay, if they brux, they could cause trauma to their teeth and surrounding structures when they're asleep. If they have poor sleep, you could have a overactivity of the sympathetic nervous system. And if you give someone chronically lack of sleep, lack of sleep, lack of sleep. That affects every aspect of their life. Okay, it could lead to excessive stress, depression, and anxiety. It changes the brain and the body chemistry of the patient. Okay, so if you look at sleep bruxism, you'll notice that bruxism, TMJ, orofacial pain are very commonly comorbid with obstructive sleep apnea. Okay, and that sleep disordered breathing is comorbid with bruxism. Okay, so it's all to do with bruxism. There's a strong association between bruxism and sleep disordered breathing. Okay, so and that's been documented time and time again. And this process repeats itself over and over again. So when a patient falls asleep, they have a decrease in oxygenation to increase their muscle tone to open up their airway. They brux. There's a micro arousal associated with the bruxism, and the patient wakes up a little bit, and they're not getting a good night's quality sleep as a result. So it affects every aspect of their life. We talked about this before, but this is the basic flow diagram. So an airway issue has far-ranging effects from a dental point of view, from a TMD point of view, from an orthodontic point of view. Okay, from a periodontal point of view, it has aspects, and from the general health and well-being of the patient, it has huge ramifications. So getting one's sleep under control and breathing properly is of great importance to the dentist. Okay, should be asking questions like, do you clench and grind your teeth? Okay, and sleep bruxism is secondary to microarousals. Okay, so you can see there's quite a bit of evidence out there that shows that there's a strong relationship between bruxism and sleep disordered breathing. And so, you know, should the patient be sleeping on their back or on their sides? And we recommend that they sleep on their sides, both sides, right and left. Okay. And patients with sleep apnea clenched more than those without. Okay. When sleeping on the side, it was better. The AHI was significantly lower than when sleeping on their back. So again, you know, if you have a sleep apnea patient, you always remind them, try to sleep on your side. Okay. So research has shown that when the mouth opens, the tongue protrudes, and when it closes, the tongue retracts. So, you know, the whole idea of keeping your mouth open is to help get more air in. So they have an airway obstruction somewhere. Okay. And protruding the tongue also stretches the palate-glossal arch and activates the glossopalatine muscle, which is innervated by the vagus nerve and results in acetylcholine production and stress reduction. So a lot of times, this protruding of the tongue, this bruxism event, has a parasympathetic effect and helps modulate sympathetic activity. Okay. So if we look at sleep bruxism, it's primarily grinding or clenching during sleep. It's the master muscle contracting, and the prevalence is in the research somewhere between 6 and 20%. So it's quite prevalent in children, and it's very prevalent in adults, and it's increasingly recognized as an issue. Okay, so nocturnal bruxism is associated with sleep disordered breathing. Okay, it's autonomic motor reflex response to nocturnal arousal at the end of sleep apnea. Okay, it's part of the sleep issue called periodic limb movement disorder. I think it used to be called restless leg syndrome, and it's part of that, and it's associated with reflux in sleep, and that's been a big field of research recently. The role of esophageal reflux, gastroesophageal reflux, with sleep bruxism and sleep disordered breathing, and there's a higher incidence in nocturnal bruxism with kids with adenotonsillar hypertrophy. So if you have enlarged tonsils or enlarged adenoids, there seems to be a higher incidence for nocturnal bruxism. Something which is very prevalent in our society, which I feel our profession hasn't fully gotten hold of, and we should be. And the way you do that is by taking a careful history, a dental and orthodontic history, a sleep questionnaire, some sleep disorder breathing questions regarding snoring, mouth breathing, restlessness, difficulty falling asleep, difficulty waking up, getting tired during the day, daytime sleepiness. All those are very, very important aspects. In our practice, we have a series of sleep questionnaires which we put for all our patients, whether they be orthodontic, TMD, or sleep patients. They have the same basic forms to fill in. Chronic mouth breathing affects the swallow pattern. You ask about reflux, allergies, and then we do a physical evaluation where we actually evaluate the patient dentally via CBCT, and we have a look at their airway, and if needed, we will refer them out to the appropriate health professional, like an ENT specialist, which is very important. We can't do everything, so we need to. It's part of a team effort. Okay, so the management is to evaluate the patient fully, and if evident, if there's a relationship between sleep disorder breathing and obstructive sleep apnea, the treatment options are things like: do the adenoids and tonsils need treating? Does the patient have allergies? Do they have turbinate hypertrophy? Okay, what's their BMI like? Are they a bit on the heavy side? What's their neck circumference like? Do they need a mandibular advancing appliance, or do they need a CPAP? Okay, you need to check to see whether they have any reflux or not, whether they have any anemia, and many other issues you would look at. But you have a checklist which all practitioners should have to rule out and to investigate further, and if need do, send to other health professionals, allied health professionals. Okay. So child versus adult, which oral appliance do I use for Bruxa? Well, bruxing, okay, bruxing is basically some kind of parafunctional activity. And so you need to, number one, get informed consent as to the type of appliance that should be evaluated. 2, see which appliances best serve the patient and whether they need combination treatment or lifestyle changes. So, it's not just give them an appliance and they're done. And oral appliances should be evaluated to see if they're effective, if they are an effective treatment by using transitional devices for a few weeks. So try this. If that doesn't work well, try something else. There are many different kinds of appliances out there, and we have to find the right one for the patient. How are we going for time? Are we over time? Okay. All right.
You're fine. No, you're fine. You're fine. Take your time.
I'm fine? Okay.
Yeah,
thank you. Thank you, doctor. So we're looking at things like, so does the patient need a CPAP? Okay. Continuous positive airway. So there can be a nasal CPAP. It can be a face CPAP. It can be just one for the nostrils. And that a CPAP, for those who don't know, was developed in Sydney, okay, in Australia, at my university, Sydney University. So Professor Colin Sullivan developed it, and it was never devised, and it was never intended for real long-term use. It was devised to treat obese patients so that they wouldn't die in the OR. Okay, so it would reoxygenate the patient so that they could survive surgery. That's what it was devised for. And so, does the patient need some kind of external assistance, like a CPAP? And if you look at the research on CPAPs, you'll see that during CPAP titration, most breathing anomalies were eliminated. So CPAP, from a short-term point of view, eliminated breathing anomalies. There was complete eradication of tooth grinding events. And if bruxism, apneas, and hypopneas are together, CPAP may eradicate them, or at least manage them very well short to medium term. Okay? Occlusal splints and bruxism. Now, this is the thing which our profession don't fully understand. Choosing the right splint is very, very important, because if you choose just a regular flat plane splint, which is what most of us are doing, showed that 40% of patients experience an aggravation in apneic diagnosis category on the nights they use the splint. Okay. The AHI, the apneic hypopneic index, means how many times they were aroused or how many times their sleep got disturbed, was increased by more than 50%, okay, in 5 of the 10 patients. Okay. The Respiratory Disturbance Index, the RDI, showed a 30% increase from baseline to splint nights. So when you design your splint, you have to ask yourself, does the splint close down the airway or does it help keep the airway open? So when you're designing your splint in the future, I would suggest that you incorporate an aspect of your splint design that would maintain the patient's airway regardless of their sleeping posture. Okay? Because a lot of splints actually close down one's airway when they're asleep. And that's why we have poor compliance with traditional splints. Okay? So the percentage of sleeping time with snoring is increased by 40% with the splint. That's a bit scary, isn't it? Okay? So the conclusion to using splints and bruxism is that if you use the conventional occlusal splints without an aspect of keeping that airway open whilst wearing the splints, then there's an association of risk aggravation of respiratory disturbances. In other words, the patient will have a decrease in airway space. Okay? So you need to be careful about the splints you make. So the take-home message is, when you make a splint, make sure the splint can maintain the patient's airway when they're asleep, regardless of their sleeping posture. Okay? If they sleep on their back, their jaw mustn't be able to fall back and close their airway. Similarly, if they sleep on their sides, you mustn't close down their airway. These are the aspects that you have to think about when creating a splint. Okay? Mandibular advancing appliances, right? And bruxism. So short-term use of mandibular advancing appliances is associated with significant reduction in sleep bruxism and sleep bruxism motor activity without appliance breakage. Okay, so the research has shown that by advancing the mandible, a lot of the bruxism gets controlled, or there's a decrease in the bruxism when you bring the mandible forward. So the main aspect of bringing the mandible forward is to open up the airway. So by opening up the airway, bruxism is less. Worth further investigation and worth further thought, don't you think? Okay. Surgery. Okay. So the most common surgery in growing patients is the tonsils and adenoids. Okay. And it's been shown that if the tonsils and adenoids were removed, then the incidence for OSA, then the incidence of sleep distorted breathing is less, and bruxism is less. Okay, so that's a good thing. Okay, a very, very good thing. And there's an improvement in bruxism after tonsil adenectomies, which is very, very good. Okay, so before surgery, 25% bruxed, and after surgery, 7% bruxed. And that's from the International Journal of Pediatric Orthodontology. Okay, so this is very important to understand. So if a child bruxes, there's a reason for it. If an adult bruxes, there's a reason for it. It's up to us to help investigate the reason for it. Okay. In the apneic patient, it's believed that the consequent co-activation of jaw opening and jaw clenching muscles, as seen in bruxism, helps prevent pharyngeal collapse. So bruxism helps maintain or resume muscle tone to keep the airway open. That's what it's saying. So one of the reasons why people may want to brux when they're asleep is that when you fall asleep, the muscle relaxes, and as the muscle relaxes, the airway closes down, because you know the airway is just smooth muscle, right? So the airway closes down, and as the airway closes down, the patient starts to desaturate. The oxygenation goes down, and the quickest way of getting muscle tone back into the airway is to brux, a sudden muscular activity like a clench or a grind, and that resumes muscle tone, and the airway is opened up again. So there's a strong correlation with that as well. Okay. So the summary to this is that malocclusion, dental facial dysmorphosis, and airway are strongly related. Airway, TMD, bruxism are strongly related. TMD, bruxism, and malocclusion and dentofacial dysmorphosis are strongly related. Okay? Orthodontic discrepancies, TMD, and sleep disordered breathing issues are all interrelated. Okay? There's a well-documented correlation and causative relationship between nocturnal bruxism and sleep disordered breathing. And our management should be cooperative management of the obstruction, and that has proven helpful in bruxism and should precede orthodontic treatment. So everything is related. Okay. So the take-home message is you need to see what the airway, even if it's an ortho patient, you need to check the airways, you need to check the bones, you need to check the joints. If it's a TMD patient, not only do you check the joints, but you need to check the airway, and you need to check the occlusion. If it's what's the last one? If it's a sleep patient, you need to check the airway, obviously, you need to check the joints, and you need to check the occlusion. So everything is interrelated. So basically, what we're talking about is the different faces of the same beast. Okay, for those Harry Potter fans, you would recognize the scene, right? So it's one beast, but three different faces. Okay, so so orthodontic discrepancies, TMD, and SDBs, sleep disordered breathing, are just different faces of the same beast. And on that, I'd like to thank you very much for your kind attention, and thank you very much for the Global Institute for inviting me to speak. It's been a pleasure, and I'm happy to take questions now. Anybody there?
Can you hear me? Dr. Lee, thank you very much.
Yes.
For this amazing presentation. Yes, you actually answered a lot of the questions, but I'm just going through the questions again. Yeah, there's a few questions that it wasn't answered. So one of the questions was, this is regarding mixed dentitions. Can you use clear aligners to expand the palate or the mandible at the mixed dentition phase?
The new generation of clear aligners is doing is getting better and better, and that's the best way of explaining it. At this stage, I don't think it's there yet. I believe that in a mixed dentition phase, an orthopedic developer which has screws in it, which puts the pressure on the bones, not the teeth, may be more beneficial. Okay, to actually develop the bones, so all the pressures on the bones and not the teeth may be more beneficial.
Got it. Okay, and this also, you kind of answered the question, but the question was, what is the best type of splint or a night guard? Okay, now that's like a 2-day seminar so you have to ask yourself first, have you assessed the patient's airway? And if you have, is there a constriction? If there is a constriction or a propensity towards constriction, then you have to make either a single jaw or a double jaw splint, right, that locks the occlusion into a protected position regardless of the sleeping posture. So there are many appliances, and I'm hesitant to talk about it because this is not a cookbook. No, right. There's no cookbook answer, but you need to be able to identify you need to be able to identify firstly where the constriction in the airway is. Is it here? Is it behind the nose? Is it the turbinates, the nasal and paranasal sinus area? Is it the nasopharyngeal area? Is it the oropharyngeal area? And if it's this area, the oropharyngeal area, then the splint design should be able to incorporate some kind of aspects that keeps that lower jaw forward, therefore the airway open during sleep, regardless of the sleeping posture. And that's the only criteria I make. You can invent an appliance and you can call it the Javid appliance if you want to. I will definitely do that. I will definitely do that, Dr. Lee. Thank you. So,
Yep.
and then the last question is, actually, there's a couple more questions. What is the best age for the parents to start the kids orthodontics? Say, if they have
The best age to start is from birth. Honestly, and it's dietary advice. Okay, so the best way to start is from birth. You get, for example, look up the website baby-led weaning, and it's all about correct function, getting to use the oral musculature correctly, and that's what I was alluding to it in the beginning. If you give a bottle to a baby, it's like me putting a fire hydrant in your mouth and saying, turning it on full and saying, drink.
Right.
And so and because if you put a baby to breast, do you see the baby actually has to work really hard to feed? Yes.
Right.
So and the way the mouth goes around the nipple and the oral musculature, the way it works, strengthens and develops this whole perioral area and gets the tongue to function correctly. Now, if you were to stick a bottle in the baby's mouth, it's like drinking from a fire hydrant. All function is lost.
Right.
Yep. So I would say from the moment they're born, we should be aiding in their growth and development. Secondly, if the baby is sleeping with their mouth open, something's not right. Something is not right if the baby is sleeping with their mouth open. Then you would check for obstructions. Okay.
I see. Great.
Yep.
Well,
And to intervene, let's say all right. I'll give you for an example. This is the short version. Believe me, there's a very much longer version. We are all born class 2s. Yes, we're
right.
all born like this.
Sure.
Our mandibles are underdeveloped. We're all born class 2s. So and then we develop, and then hopefully we transition into a class 1 skeletal, and we stay there.
Right.
Yes. So if you see a class 3 before the age of say 9 or so, there's a strong environmental factor and not so much a genetic factor involved. There is a genetic factor in class 3s, but you don't see that expressing itself till later, because to get to a class 3, you have to go from class 2 to class 1, then class 3.
That's right.
As you grow and develop. So if you suddenly see baby as a class 3, then something's not right. So they're doing some kind of postural compensation of sticking their lower jaw forward, and it's usually to try and breathe. So how young should you intervene? As soon as you see a problem, get someone to look at it.
Got it.
Because it's all about establishing correct function. If you establish correct function, then most of the oral posture will be correct. The dentition will be approximately correct. The joints will be approximately in the right position, and the airway will be the right size and shape. Okay.
Absolutely.
So all the major problems will be minimized.
Great, Dr. Lee. Thank you so much. We appreciate you very much for coming on and sharing your knowledge with us. Amazing information, Dr. Shaw. Oh, we can't hear you, Dr. Shaw.
Well, what a great show we have had tonight. Thank you so much, gentlemen, for joining.
Thank you.
We need to have this interdisciplinary approach in dentistry where we learn from orthodontists and pedodontists and endodontists and prosthodontists, and on it goes. So I really appreciate your orthodontic perspective on the topic, and really appreciate you hosting the session as always.
Thank you, Dr. Lee.
Thank you, Dr. Shah. Thank you, Dr. Shah.
Wish you guys a wonderful evening, and let's see our friends and colleagues in, I believe, 12 hours or so. 12 and a half hours we'll be on for the next show.
Thank you.
Have a good day. Have a good night.
Have a good day. It's been a pleasure. Thank you very much.
Pleasure was ours. Thank you, Doctor.